Hello everyone, and welcome to today's show, Information in the Bedroom. Today we'll be talking about posterior lumbar internal fusion. This would be part 2, the tits and tats and this and that. So we'll get right into it. My patient profile is Mark Mayu. He's a 39-year-old male. He's physically fit. He lives at home and has a large family and a great support system. The patient is a smoker and has a history of sinus problems and has no other pathophysiologies, and the patient is having the PLIF, posterior lumbar internal fusion. Why is he having this done? He ruptured the disc between L5 and S1 in his spine, so that is why he's presently taking Tylenol 3 to help cope with pain. For the anatomy portion, we'll switch to my good friend and scientist, Dr. Longbottom. To you, Dr. Longbottom.
Thanks, Marie. Hello, everybody. My name is Professor Longbottom, and today I'm going to help out my good friend Marie, and we're going to go a little bit over the anatomy of the spine, okay? So just bear with me. You're not going to see my face much. I'm going to show you how some things work. Now, I know what you're thinking. God darn it, that grapefruit looks delicious. But what actually is going on here is I've built you a vertebra. Now, a typical vertebra has a drum-shaped body that forms a thick anterior portion of the bone, and a longitudinal row of the body supports the weight of the head and trunk. The intervertebral discs, which separate joining vertebrae, which are here, are fastened to the roughened upper and lower surfaces of the bodies. These discs cushion and soften the forces created by walking and jumping, which might otherwise fracture the vertebrae and jar the brain. So each intervertebral disc is composed of a band of fibrous fibrocartilage which surrounds the gelatinous core called the nucleus pulpus. So if I take off my disc and my vertebra, there, right here, you can see that this here is called the nucleus pulposus. The bodies of the adjacent vertebrae are joined on the front surfaces by anterior ligaments and on the back by posterior ligaments. So, anterior and posterior. Projecting from the back of each body are two short stalks called pedicles right here. They form the sides of vertebra foramen. Between the pedicles and lamina of a typical vertebra is a transverse process, which is here and here. That projects laterally and toward the back. Various ligaments and muscles are attached to the spinal processes and the transverse process. Between the pedicles and the lamina of a typical vertebra is a transverse process, as you can see there. That projects laterally towards the back. Various ligaments and muscles are attached to the spinal processes and the transverse processes. Spinal processes and transverse processes. Projecting upward and downward from each vertebral arch are superior and inferior articulating processes. These processes bear cartilage-covered facets by which each vertebra is joined to the one above and the one below it. On the surfaces of the vertical pedicles are notches that align to create openings called intervertebral foramina. Sorry, that was intervertebral foramina. It's a hard word to say. These openings provide passageways for spinal nerves that proceed between joining vertebrae and connecting to the spinal cord. So not only they would come through here, and also they'd run up this way. Well, I hope you've really liked my helping out Marie and telling her about the spine, and all of you. So if you ever have any more questions, don't feel free to Google it because I probably can't give you the answer again. Okay, thanks. Ciao. Back to you, Marie.
So diagnostic tests that would have had to been done include MRI, CT, as well as X-rays. The patient will be opened at the lumbar spine, dissected past the lamina. The ruptured disc will be removed through a small window. 2 spacers will be inserted, and bone grafts will also be inserted into that space that are from the patient's iliac crest. And the outcome will hopefully be that there is a spinal fusion, the patient has more normal range of motion, and is free of pain. Regarding preoperative preparation and education, the patient will need to know instances of success with the procedure, what to expect, possible adverse effects of the procedure, not to eat and drink before surgery except for clear fluids a couple hours before, surgical activities and restrictions, signs and symptoms of donor rejection, as well as infection and medication usage and hygiene. The incisional approach used will be a medial lumbar incision. Sinusitis. Ruptured disc at L5S1. CT, X-ray, MRI. Used to look at the procedural area and identify the injury, the extensiveness of the injury, and the procedure needed. Pain medication. During the procedure, the patient will also receive ketamine, propofol, succinylcholine, and a local anesthetic. PLIF, posterior lumbar internal fusion set, as well as a graft set. A PLIF dissector, holder, impactor, spreader, rectangular bone curette, osteome trial spacers, detachable spacers, and a bone rasp, as well as intervertebral disc shavers and excisors, graft funnel, graft packer, graft pusher, graft holder, and a quick release T-handle. Have x-rays in the room. Have access to possible instrumentation sets and special tools that may be needed. PLIF spacer, radiograph to assess the patient's best positioning, fluoroscopy, cautery, vac, and drainage tube. Incise and dissect the skin from the midline laterally to locate the spinous process, lamina, and dura. Perform a laminotomy and expose a 13mm window. Remove the disc through the window until only anterior processes and annuli remain. And remove the nucleus pulpus and superficial layers of the cartilaginous end plates. Superficial layers are removed completely to expose bleeding bone and facilitate vascular supply to the graft. That's done using the intervertebral disc shaver and excisor. Distract the disc space and determine the implant size using the PLIF distractor, Lades PLIF trial spacer. Insert PLIF spacer and ensure the proper fit. Insert autogenous graft and second spacer. Do that using your T-handle, PLIF spacer, PLIF detachable holder, PLIF impactor, graft funnel, graft pusher, PLIF graft packer. And close. So how would you do that? You'd use sutures, and what kind would you be using? We're going to use a number 1 and a number 0 Vicryl braided multifilament for outer skin and a 2.0 Biosin absorbable for the internal muscle layers and lamina. And if we're going to break down the dressing, I'll be using Adaptic, Telfa, ABD pads, and cling. So post-op, we can expect that there's a chance of the donor not adhering to the site and a failed fusion, chance of scar tissue causing pinched nerves, chance of paralysis even if the operation doesn't go well, and a chance of chronic pain and a chance of limited mobility for eternity. So what is the outcome for my patient? The patient was sent home the next day. His outcome was a failed fusion and his sciatic nerve being caught up in his scar tissue, chronic pain, emotional disruptions of his life and family stressors, and the inability to function normally and extremely limited range of motion. Post-op instructions for our patient include no bending, lifting, twisting, sitting, standing for too long, normal diet, assess pain, medications, and effectiveness, watch for bloody stool, post-surgical activities and restrictions, signs and symptoms of donor site rejection, as well as the signs and symptoms of infection, and medication usage and hygiene. Our patient can expect to have home care. to change his dressings and assess for signs and symptoms of infection, physiotherapy to assess his range of motion, follow-up MRIs and x-rays as you can see behind me, and CT scans to assess the progress of the fusion, occupational health to assess home functions and facilitate maybe making ADLs easier, have a diet with plenty of protein to help muscle building, increase probiotics due to use of antibiotics.